Assalamu alaikum. My name is Mayat Fatma and my roll number is 94 and my topic is fungal endocarditis. Fungal endocarditis is a very rare and fatal condition, specifically conducted by two species, Candida and Aspergillus. The most ordinary clinical expositions of it could be fever and changing heart murmur. The diagnosis is pretty challenging and sometimes quite difficult to carry out without any strong leads. As it is mentioned in this paragraph, how disputable the optimum antifungal therapy still is for us to follow up to. When it comes to treating the Candida endocarditis, it can be very arduous since Candida species has the ability to form biofilms on native and prosthetic heart valves. Moving on, here I present you a case study regarding our topic, looking quite lengthy, but don't worry, I'll be making it very easy for you by only focusing on the main points. So the first thing we look at is that our patient is a 35-year-old male heroin addict and was hospitalized due to his pleuritic chest pain, NDOE, which basically means dyspnea on excretion, meaning shortness of breath. After the conduction of a physical examination on this patient, we came to know about quite many deformities. We found out that the patient is pleuritic, meaning that the patient, due to an unknown disease, is losing muscle and weight. Next thing you see here is the temperature, which is 104 Fahrenheit. Now keep this temperature in mind because this will be the confirming of the deformative variance in our case study. Now we also see that there is diastolic regurgitant, heart murmur, and it is heard loud during inspiration. And this we all should be worried about. We also see splenomegaly, which is enlarged spleen, pharyngeal petechia, which either could be mononucleosis or streptococcal pharyngitis, specifically affecting the soft palate. Now, do you remember the temperature 104 Fahrenheit I mentioned above? The temperature confirms this pharyngeal petechia scientifically. Next comes the non-contributory fendoscopy, which is also known as the ophthalmoscopy. Some pulmonary infiltrates found could be pus, blood, protein, basically anything denser. There's blood in urine, vegetations, which is abnormal growth, or tricuspid and aortic heart valve. Moderate heart failure, but along with hemodynamic stability. As written, 6 sets of blood cultures were drawn over the period of 2 days, and broad-spectrum empiric coverage consisted of vancomycin, gentamicin, and ceftazidime. Now, after 2 days, 2 cultures grew Candida albicans species, confirming the fungal endocarditis. So here, 2 questions arises. What would be the prognosis? And secondly, how can we treat it? Prognosis meaning the outcome. So firstly, I'd like to mention people who are more prone on getting this fungal endocarditis. And those people could be IV drug users, immunocompromised, or they could already be having prosthetic heart valves. Now comes the management. When it comes to the management, we can apply certain things to help the patient. First, an early valve replacement would help. Then, aggressive fungicidal therapy. In this aggressive therapy, we give a combination amphotericin B with 5-FC, just 5-flucytosine. The doses are mentioned in front of you, and we give this in combination orally. And by giving this combination, we agree that we'll be discontinuing our previous spectrum which was vancomycin, gentamicin, and ceftazidime. Now, what should we do about the chest radiograph situation? So the issue comes under this would be pulmonary infiltrates, cavitation, enlargement of spleen and kidney, and possibly other vital organs. So we will be recommending surgery within 48 to 72 hours after the initiation of medication therapy, of course. Delaying the surgery would risk a patient's mortality. Now the question arises is that why this combination? Why are we selecting 5-FC and amphotericin B? So despite of 5-FC having the potential of causing bone marrow suppression and hepatotoxicity, scientifically, we're still warranted to give 5-FC along with amphotericin B. Although this combination still yet haven't been adequately studied, so we carry a poor prognosis regarding this combination. We know about the vegetation situation at the tricuspid aortic valves area. So knowing the dangers of 5-FC, we'll suggest patient blood tested with these drugs individually to observe the outcome and then maybe go for the overall combination after monitoring well. And if the organism is resistant to 5-FC and in vitro synergy between these two antifungals is lacking, then we won't indicate continuing it. Now, the duration of therapy. We still aren't clinically sure about it. However, post-operative treatment of the two antifungal combinations medications can be given for a minimum of 6 weeks. The dose of amphotericin B is shown. This would be enough and will be supported by the poor penetration in heart valves tissues. Since relapse is an issue in this matter, so the expert suggests a minimum of 2 years period for secondary prophylaxis treatment, especially in non-surgical patients. Why limiting the amphotericin B dose? Simply because high doses of amphotericin B causes nephrotoxicity, which leads to the dose limiting factors. What could be the alternatives? So we have 4 alternatives, but these 2 would be the main one. Knowing the toxicities surrounding our 2 antifungal medications, nephrotoxicities, hepatotoxicities, bone marrow suppressions, and much more, what possibly could be the alternatives? We have fluconazole and caspofungin. Situation with fluconazole. So fluconazole was effective in eradicating cardiac fungal vegetations caused by Candida albicans and Candida parapsilosis in a rabbit mode. In human, only successful in few cases. But the main issue is that fluconazole favors the toxicity profile compared with amphotericin and 5-FC, leading to nephrotoxicity, hepatotoxicity, and other problematic features. Patients were treated with 200 to 600 milligrams of fluconazole daily over the period of 45 days or till death. However, this therapy could only be recommended for 3 types of patients or 3 types of conditions. Number 1, the patient who are poor surgical candidates, patient who has relapsed at least once, and patient with portal vein embolism. Now, the situation with caspofungin, a first-line agent in the E. coli class, approved by FDA for therapy against esophageal candidiasis, invasive candidiasis, aspergillosis, and bloodstream primary infections. Caspofungin is fungicidal against most Candida species. It inhibits fungal cell wall synthesis by inhibiting beta-1,3 glucan synthesis. Compared to fluconazole, it was more effective with many accepted cases. Given with amphotericin B and continued as maintenance therapy for 12 weeks, especially to the patients who didn't go through any surgical oppositions. Now, lastly, what's new? So, micafungin and enidulafungin are in the latest addition to the echinocandin class. Echinocandin class. Clinical experience in the treatment of endocarditis is currently lacking for these two drugs. So there's not much to discuss about these two. Thank you so much for listening.